Well, welcome to this most recent episode of the Akkad and Coca Report. Today we have the pleasure of having two guests. We have Dr. Rupali Chadha and Dr. Marion Mass. Dr. Chadha is a forensic psychiatrist trained at Johns Hopkins, now is enjoying a practice in Newport Beach. She is here as a advocate and a recent visitor to Washington, D.C., who's kind of witness to and kind of helped push through the executive order that Donald Trump signed. Donald Trump recently signed 4 different executive orders. One of the executive orders focuses on middlemen in healthcare. And we don't talk a lot about middlemen in healthcare, and that's partly why Dr. Chadha is on. And again, none of this probably would have been possible with the other guests that we have, Dr. Marion Mass. Dr. Marion Mass is a pediatrician who's trained at Duke, who now practices in the Philadelphia area, and she's been a super strong and really, very knowledgeable person when it comes to healthcare policy. We frequently find in medicine and healthcare that everyone wants to run around saying that something's wrong. It's easy to see something's wrong. Dr. Mass is one of the few people that I think has kind of put everything together and has a very deep set of knowledge that allows her to see what the problems are. She's written extensively on this topic and really has inspired a lot of us to kind of get involved in healthcare as well. So super excited to have her on as well. We've been meaning to have her on for a long time. And when this executive order was signed earlier this week or last week, we thought this would be the perfect time to have her on to kind of help educate us a little bit. As I said, what's wrong with health? So thank you both for coming on.
A pleasure.
So we'll start, Marion, with third-party middlemen in healthcare. When did you first realize that middlemen in healthcare were kind of a big problem?
I founded Practicing Physicians of America with Westby Fisher in 2017, and we kind of came on in a big splashy way, and people were paying attention to the mock reform that we were doing, but we were extending and starting to talk about other issues in healthcare. And I was approached by some people, including Robert Campbell, a anesthesiologist in Pennsylvania here, and he made me aware of the issues behind the pharmaceutical supply chain. He was concentrating mainly on group purchasing organizations at the get-go. And as I started to understand more, I was really shocked. I mean, in the big picture, to summarize it for patients, they're all paying more and they're getting less. And that happens year after year, right? Like they're all feeling the squeeze. And so it's clear that there's just people behind the great curtain that must be sucking the money out of there, right? And people very simplistically blame it on insurance, pharmaceuticals, and doctors. I think those are like the 3 big blame games. But when you start learning about the pharmaceutical and hospital middlemen, you realize that they're making more money than the pharmaceutical people themselves and offering very little in value. So I started more deep study. And so it was about 2.5 years ago.
So, let's start with GPOs, group purchasing organizations. Now, GPOs ostensibly exist to actually lower healthcare prices, right? The idea was that you had a bunch of hospitals that needed supplies, needed pacemakers, needed syringes, needed whatever it is hospitals need to run, beds. The idea was that if you could group purchasing power, you could get folks to combine their purchasing power, get multiple hospitals or multiple health systems together into one unit. You could have that unit then kind of buy things and be able to leverage and negotiate significant discounts from the people that were providing those services. So it would seem like that was not a bad idea to be able to get beds and IV pumps and syringes for cheaper. What went wrong, Marion?
Well, the government got involved. It's usually a harbinger of a bad event here. And, honestly, I think that when laws are enacted, sometimes maybe people think they're for good reasons and then they have an unfortunate consequence. But I don't know what anyone was thinking in allowing kickbacks to be legal in 1987 for these group purchasing organizations, which since that time have condensed to where 4 companies in America are
Right,
controlling.
right. So Marion,
Yeah.
so initially when it started
Mhm.
as kind of like a buyer's club, right? So almost like Costco, where you have hospitals that pay a certain membership fee to join this large, this consolidated place where you can essentially get stuff, correct? And then in 1987, was it? That's when there was a legislative change made.
Right. It was within the Medicare, Medicaid Patient Protection Act of 1987.
Right,
They simply gave them a free pass to be able to receive kickbacks. They
right,
wrote it in nicer language, but
right.
so the people that are they became the gatekeepers then to the entire hospital supply chain.
Right. And so what happened is that in 1987, instead of the hospitals paying some membership fee to this GPO, and that's how the GPOs were paid for, now the group purchasing organizations could be funded by payments from the manufacturers of devices, syringes, beds, IV pumps, etc. Correct? So
And
it could
95
be
masks, yes,
right.
you
It
name
could
it.
be it could be a percentage of the sale that you're getting. And that's generally that's considered a kickback, and so there's actually laws on the books that prevent that. And in 87, there was a law passed that exempted them from those kickback laws. So essentially, it allowed these middlemen to no longer have to charge a subscription fee to hospitals. Now they can simply get a percentage of revenue of the sale of, say, so if hospital A wanted 100,000 N95 masks, um, the GPO will essentially say, okay, these are and the GPO selects which companies have those N95 masks, and depending on what company they select, they get a percentage of that total value of that sale, which completely takes away, if you're getting a percentage of that total commission of that total sale, it kind of takes away the incentive to necessarily get the lowest cost per se. And there's also there also can be incentives to get on that list of who N95 manufacturers, right? So there may be a lot of dealings that go on, which allows certain N95 manufacturers to be on the preferred purchasing list of the GPOs.
Well, you're right. No one knows, but like
Right,
once you put the position of arranging a gatekeeper, and
right,
that gatekeeper is plied by money, you're not plying the gatekeeper by quality anymore.
right,
I mean, you're a
right,
cardiologist, you're
right,
correct.
right.
So
Yep,
you have devices, you have pacemakers that you put in. Cardiac surgeons who put in devices in the middle of cardiac surgeries.
right.
Those devices are not chosen by you, they're chosen by the GPOs. These are not medical
Right.
doctors. These
It's
are
interesting.
businessmen in
Right.
suits.
Right. It's really interesting how it works because, as a private practice, I mean, I'm not a hospital, so I'm not big time, I'm small time. So I order, so I order, I buy echo machines, and I buy ultrasound machines. I buy other types of machines, and I don't go through GPOs again because I'm a super small person. I just go directly to the manufacturer and buy them. Marion, why, if it's the case that GPOs are kind of inflating the costs of these products, right? And inflating the cost, and they're not necessarily the highest value. What is to keep hospitals from going directly to the manufacturer, like I do? Like, I'm not going to go to some GPO that's going to sell me an echo machine that's 2x. I'm going to go directly to the manufacturer and say, is this the cheapest thing that you can offer me? What's the best deal? So
Right.
why
Now,
why why aren't they going directly to the manufacturer? Because hospitals, they're rapacious in terms of profits. So you would think that they would. This would be like low-lying fruit.
a good bit of this is shooting in the dark because we don't see the contracts. When the law was made, the oversight in the law was that the HHS OIG could ask to see those contracts at any point. And the contracts are supposed to be kept to less than 3% of the total sale of the product. But as you
Right.
pointed out, more expensive product, you're going to get more. So you're perversely incentivized there.
Right.
And then we don't even know that they're keeping it to the 3%. But the hospitals, for all you know, and from what we have heard and what some people have let slip, the hospitals are often given share backs for participating. So if they purchase X percentage of product through GPO Y, then they receive a share back that comes as a one-time payer fee that's going to someone within their supply chain. And then what unfortunately we see, and it's kind of ugly, you'll see major hospitals that have people that sit on the boards of these GPOs. The president of Johns Hopkins University Hospital himself is on the board of one of the big GPOs called Vizient. Makes us all sweat. And by the way, right after he got there, he turned all of the supplies over to Vizient, which must be worth billions. It's just a bad look, doesn't pass the sniff test.
Right. No, that's absolutely right. So you get the sense that hospitals are, part of the reason we talk about how expensive healthcare is all the time, and part of the reason healthcare is so expensive is because the hospitals say, well, our margins are so small, we're barely eking by. And then you look and it's like, a Tylenol, each tablet is $15, and each IV pump is, they're spending $6,000 on it and stuff. It's like, where is all this money going? And if it's the case that the hospitals now have an ownership stake, or certain members of the hospital, folks who run the hospitals, have an ownership stake in the GPO as well, it gets to be an awfully cozy relationship where a bunch of people are making a lot of money on the backs of Americans and American taxpayers. That's for sure. What's
Absolutely.
we'll talk about. And there's some really nice links that you've provided about a small business owner who discovered how to make a retractable needle to kind of avoid needle sticks, right? And he had this great business, great idea. The hospital, Dallas Presbyterian, was all excited. They were like, oh, we're going to do this. We're going to reduce needle sticks. And basically he couldn't sell to Dallas Presby, even though multiple doctors there had invested in the company, were like, this is great, we should do this, because the GPO would not put this guy's company on the preferred list, right? So the GPO has these, so it again points to the fact that the GPO may have these kind of backhanded relationships where everyone is patting each other on the back to kind of figure out who stays on the list or not. Interestingly,
there's something happening. Go ahead. I'm sorry.
No, sorry. Yeah. So interestingly, is it possible, Marion, that the reason folks like this relatively small company wasn't able to break in, is it possible that it's a quality thing, that it's a value thing, that they're just not able to generate the type of volumes in terms of, all right, we need 10,000 of widget X by Friday, and a small company may struggle to provide that, but yet these large, massive companies that have supply chains that extend around the globe, before COVID, they were able to kind of snap their fingers and kind of provide that. Is it possible? Is it plausible that that's the reason why some of these smaller firms that say that, hey, we have value at lower cost, but we're not getting on the GPO list? Do the GPOs and the hospitals have a point in saying that these guys aren't necessarily able to fulfill what we need?
Well, I mean, my goodness, look at just since COVID started, how many egregious examples we have of very, very needed products that came in via crappy quality. Right. And, one hates to pick on a certain country, but, it's very well known that China has taken over a lot of our supply line, and not to a quality advantage. The company that made 9.1 million gowns that were recalled in January, gowns, surgical gowns. We were 9.1 million short.
Right.
These were gowns that were made in China. They were the preferred supplier at that point.
Right.
That was January 2020. We got a memo that the FDA all of a sudden told us that masks that were also made in China, they couldn't be reused because they weren't passing muster. So just since COVID, just in that short time, we hear that there's two very essential products that are of poor quality that were the chosen products, that were the ones that were getting into all the hospitals. That's a huge concern. I mean, I've heard Anthony Fauci say on podcasts that the fact that things are being made overseas and we don't have the quality control, we didn't know that before COVID. Well,
Right.
I did. I was telling people 2 years ago.
Right. Yeah, these supply chains that extend around the globe certainly have been exposed to be super fragile, especially as as things that you knew, but certainly COVID really exposed those flaws. Let's talk about pharmacy benefit managers real quick, and then we'll talk about your advocacy and Rupali's visit to Washington. Rupali goes to Washington. Is that going to be a movie, perhaps?
I hope not.
So PBMs, again, these middlemen that are, that slink in the darkness that nobody really pays a lot of attention to. Pharmacy benefits managers, again, the idea was pretty good, right? The idea was that you had these folks that, wanted cheap drugs. And so PBMs came into being because they are these giant buying networks for drugs. They represent consumers from multiple employers and insurers. So, Aetna has all these patients. There's millions of patients that are insured under there. Aetna wants to offer a prescription drug plan, and hey, that prescription drug plan, they don't want to break the bank. They want to have relatively low premiums for patients. So why not have aggregate on your buying power, not just with Aetna but United and Blue Cross, whoever, and come together so you have these pharmacy benefit managers who say, all right, we represent Aetna, United, so and so, which represents 200 million people, and they go to the drug companies and say, we want lower prices. If you will lower your price for this drug, we will put you on our preferred list, and therefore you will accrue lots and lots of volume and therefore profit. So that's the strategy. What happened? What are your thoughts on PBMs, Marion?
Well, I mean, I'll say the same thing I should have said for GPOs. Yeah. Like, you said to me, is it working? Are they saving money? Yeah. I don't know. Do you see hospital costs going down? And those supply chains are like 20 to 40% of all hospital costs. That's a huge chunk. Right. Do you see drug prices going down?
Right.
I don't think anyone in America does. So when you have these people that have the power to select what goes on a formulary, and they're given the gigantic conflict of interest of being able to take money from the people who are trying to get their drug on the formulary, it's the same as it is for the GPOs. It becomes pay to play.
Right.
And once again, no one sees, no one knows, because no one is looking at those contracts. HHS, OIG has not asked. No one's looked at the contracts.
The interesting thing with pharmacy benefit managers, which may be similar to GPOs, the GPOs I think work partly, it's mostly commission based. The interesting thing with PBMs is that their revenue sources, it's really derived from three different places: fees from the supply chain, rebates from manufacturers, and pharmacy spreads. And pharmacy spreads is the difference between what they pay for drugs from a pharmacy and what they get paid by the insurer. So the idea is to incentivize PBMs to get these massive reductions from the list price, right? But effectively, what happens? What happens is that in order for everyone to make a nice amount of money, you get a drug company that just jacks up the list price, right, of something that may cost $1 to make or something. They may jack it up to $1,000, right? And then they tell the PBM, hey, we will give this to you for $100, and the PBM will then be happy because they're making money off that spread, that difference between what they pay for the drug and what they get paid by the insurer. So that it basically inflates the list prices of these drugs, and at the end of the day, no one's really the patient, not no one. The patient isn't really seeing massive benefit. Commercial insurers have started complaining a lot about PBMs, and the specific complaint is that they're not passing through the rebate revenue they should. And everyone kind of knows this. MedPAC, the Medicare Payment Advisory Commission, has consistently raised concerns that PBMs are not choosing the lowest cost drugs, because that's what should be happening, right? If you have 10 different ACE inhibitors and 3 of them are massively expensive and the rest are generic, but they work just as well in the RCTs that cardiologists love running, then the PBM should say, hey, you can use this drug and it'll be, that'll be fine. But it turns out that PBMs are failing even there, and that the PBMs are not choosing the lowest cost drugs. There's some recent study that suggests that PBMs are charging Medicaid managed care organizations, MCOs, much more for generic drugs than they're paying pharmacies. So I think, and part of the problem is that you may start out with good intentions and then ultimately you get bad things happening. Just like you've had a lot of consolidation in the GPO market, you've had lots of consolidation in the PBM market. There are basically 3 large PBMs now: CVS, Express Scripts, and United Health's Optum. They account for more than 70% of all claims volume. So this concentrated market share, it should allow PBMs to extract deep concessions from the rest of their supply chain. But because of this kind of how they get reimbursed, they're not, value isn't necessarily being transferred to patients. So if you, so the goal is not, I keep repeating this just to make sure it gets through, that PBMs aren't necessarily paid the most based on selecting the lowest price generic and putting it on their preferred list for their customers. What they get paid for is getting the largest rebate, or they get paid more if they have a larger rebate. And so instead of putting the lowest price drug on the formulary and passing the savings to insurers, PBMs simply supply the drug with the highest rebate. So pharma, of course, isn't super happy with this because the rebate just increases the list prices. Premium insurers, the commercial payers aren't happy because the lower premiums there aren't lower premiums, which can't be passed on to insurers and stuff. So these are big time problems, and of course a lot of this is shrouded in secrecy. There's a lot of all of this is opaque. So the MCOs, Medicaid managed care organizations, I think I saw recently they were trying to figure out what these backroom deals were and exactly how much was being paid, and it's kind of challenging to figure out. So those are some big time problems with GPOs and PBMs. And Marion, you have been really out front in terms of sorting and kind of sussing out that these, something's rotten in Denmark, clearly with these middlemen. How did you go about, pushing for change, and do you think that the executive order that Donald Trump just signed regarding middlemen, can you explain how you got to this point, and then what exactly the executive order does?
Well, I didn't write the order, so.
Oh yeah.
And I will say that the executive branch cannot do anything other than try to redirect the kickbacks, the things they call rebates, right? So they euphemistically call them rebates. What does this executive order do? The number one good thing that it does is it reterms them as kickbacks, because they are kickbacks. And once we start calling them kickbacks, then people will pay attention and realize we've got to do something about this. The second thing that it does is it supposedly should redirect them at the patient in the Medicare space. And it's the Medicare space only, and only for PBMs, because the executive branch can do nothing at all about the GPOs. The GPO kickback safe harbor, the safe harbor legalizing kickbacks, was done as an act of Congress. The PBM kickback safe harbor was added by HHS. HHS can only redirect them. They can't get rid of them. So calling them kickbacks helps, redirecting them to the patient helps. But now, you mentioned a lot of consolidation in each of these spaces, but there's also additional consolidation between spaces. So as you likely know, CVS Caremark, the big PBM, just decided that they were going to buy Aetna. I mean, who has 64 billion lying around? Well, you do when you're CVS and you're a PBM. And incidentally, 60% of CVS's revenues come from its PBM. So think about what a cash cow those PBMs are. You thought it was all of the little braces and Tylenol and floaties for the pool that they're selling in the summer. It's not. It's their PBM, right?
Yeah, it's almost like they're laundering money. It's like they have this front where they're selling toothpaste, but really the big money is in PBMs and stuff. It's interesting.
Yes.
What do you think, Rupali? Should we go into business? And this should be a good plan. We should form our own PBM.
No, absolutely not. Not at the expense of the American patient.
Good answer. The Coca Chadha PBM isn't going anywhere. Specifically, it excludes, the order excludes from safe harbor protections under the anti-kickback statute these particular things. So does that mean, Marion, that that these kickbacks will go away? Well, I mean, I'm a little confused. Are you saying that the executive branch doesn't have the power to do that?
They don't. Like,
Okay.
So this only supposedly redirects the money to go back in the pockets of the Medicare patients. And then, but there's a little loophole in it where they say they'll only do that if the premiums are not raised. So going back to now, insurance companies and PBMs owning each other in one shape or form or another, the insurance companies can simply say, uh-oh, we're not making this money through kickbacks now, we're going to raise the premiums. And if they raise the premiums, then the order goes away. So it's a little bit of a game of chicken.
Right.
Really, honestly, to tell you what really needs to happen, and this is how America's supposed to work, we the people have to kind of get their heads together and figure out there's a lot of money in drugs, there's a lot of money in hospitals, and the people that are controlling the hospital supply chain and the people that are controlling the pharmaceutical market are middlemen that don't do any manufacturing. They don't even move the stuff around. They have distributors to do that. They have henchmen to do that. What do? They write contracts. They sound like a bunch of bookies, and they're allowed to receive kickbacks. Why do we have kickbacks legalized in this space? Beyond me. The public should be up in arms, but they don't seem to, a lot of them aren't digging deep enough to see that, and they simplistically blame pharma, they blame insurance, they blame doctors. They're not digging down and seeing that there's these giant corporations that are controlling what medications you choose, I choose, or what's in the hospitals and the supplies.
Right.
And hurting everyone.
It's unfortunate that it is this game of chicken, right? It's almost the case that if requiring some type of safety net, not blinking, with these kind of almost hostage negotiations that take place, would probably result in some significant value being given to patients. For instance, I mean, it's already happening, right? It's happening in the sense that there's been greater and greater shift in order to keep premiums down. You've had all this cost shifting that's happened to patients, right? And so suddenly, this insulin or that insulin isn't covered. And what is the market? How has the market responded? Walmart has created, the insulin, the twice a day insulin that you take, that's long acting, not Lantus, but has created insulin to, that's, it's basically $25 for a month's supply. Walmart, Target, other larger centers have these $4 per month plans where you get a month's worth of medicines for a list of meds for relatively cheap. GoodRx has emerged. Of course, GoodRx may have its own kickbacks going on in terms of who's on the GoodRx formulary and how people are getting on. But regardless, GoodRx is kind of a way of getting the benefit directly to the patient, right? So however GoodRx is negotiating with whoever behind the scenes to get low cost cash payments for a lot of different meds, they're kind of giving that discount that they're able to get directly to the patient. So it almost seems like if you just, if somebody just didn't blink, if somebody didn't, in this game of chicken, that we would get a lot better value for patients, because at the end of the day, you have patients that have needs, and you have a lot of different folks that exist to kind of fulfill those things. What happens, it seems like, is that you have these third-party middlemen that come in saying, oh, we're going to take care of this for you so that you don't have to worry about it, and they just end up making massive amounts of money off of, without doing too much, but just providing some type of a weird safety net that isn't even really that good. I don't know what the solution is, other than getting the government kind of as much out of the way as possible to allow the market to work. A lot of people are super scared of that, but it seems like there's a lot of good responses that happen if you just give it a little bit of time. How did you guys, can you tell me a little bit about how you made this happen? How did you get this executive order even signed? I mean, This has been a big push of yours, Marion, for both Democrats and Republicans. I know you've talked to multiple folks on either side of the aisle, and folks have been pretty resistant. Was there any particular things within this administration? Can you tell us a little bit about how you advocated for this and how you and Dr. Chadha and stuff ended up, heading up to DC?
Rupali, you want to talk about like the first time you came to DC? Because I think that's like, it's important for physicians to know that they can really affect change, even when they've not been involved in the past.
Yeah, absolutely. So I was mentioning before we went on live that I was very angry. I saw that medications were costing way too much. My patients had difficulty accessing them, and we had shortages of very, very simple medications like lithium or Haldol, since I'm a psychiatrist. And so I heard Marion was going to DC and that there was a policy council that was going to meet. And I decided, hey, what do I have to lose? I'll just go listen. And it was a fun trip to DC and made a lot of lasting memories and friends. But I also learned a lot. And I learned that there are doctors who are banging down the doors of congressmen and women and shouting from the rooftops. And even if nothing drastic is happening, something is happening. And so I got involved with Marion's group and with Free to Care. And I started doing congressional town halls with new candidates who are not yet murkied by the swamp, and told them, hey, there are these things, they're called rebates, but they're actually legalized kickbacks, and they're hurting your constituents or your potential constituents. So I got involved, and I have been doing this now for almost 2 years, I think. And
this is since Free to Care started. So this is all through Free to Care. Is that correct?
It's correct. It's all through Dr. Mass, through Marion Mass, right here.
Yeah,
on with it.
There's more than just me. There's 70,000 doctors in that group.
That's wonderful.
But you've been very inspiring because, you don't give up. You have a busy practice. You have a lot of kids. You have a marriage that you maintain beautifully, and yet you do this. And so I thought, hey, I have a lot of time. And I'm pretty pissed off, so I'm going to do this too.
That's awesome. So, I mean, are these meetings that are organized by Free to Care in terms of meetings with congressional candidates, or how do you do this, Marion? Or I mean, Rupali, whoever. Rupali, you said you met with these local candidates and stuff. Did you just cold call them, or how does one go about?
Initially, Marion helped arrange the first town hall that I did, and then I did get involved with congressional candidates in my own district or neighboring districts. And a lot of times their campaigns would reach out for a donation. And it doesn't matter what side of the aisle. This is a nonpartisan issue. This is not a Democrat, Republican, Libertarian issue. This is an American issue. And so when candidates would reach out and say, hey, I'd love you to make a donation, I said, I have something even better for you. I will come free of charge, give a town hall, and tell you how you can help fix healthcare. And a lot of candidates, they took the bait. They were like, yes, for sure. Come on by. Free town hall, love it. So initially it started through, Free to Care and some organizations Free to Care works with. And then I just took the onus and said, hey, I have my little pocket of Southern California, the Inland Empire, Los Angeles, San Diego, and Orange County. I'll just attack right there.
Wow, that's really amazing. So it sounds like you have a lot of pretty remarkable physicians in this group that kind of take the ball and run with it. So that's fantastic. Is that, Marion? Is that what you recommend? What would you recommend that physicians elsewhere who want to get involved do? And the other thing, just to talk about, I mean, there's politics and polarization and stuff. It's really tough these days, but. These issues that we're talking about, I mean, these aren't partisan issues, right? I mean, problems with the GPOs, problems with PBMs. So, regardless of what our individual politics are, we should all come together to kind of push both Democrats and Republicans or Libertarians or Green Party members to kind of, make healthcare better by addressing some of these inefficiencies. Do you think that's and is that what you find? You find both members from both parties pretty receptive to this type of message?
Well, I started with physicians, and the paper was like, it was directed at lawmakers, but with the with the idea that physicians would read it. So in the spring of 2019, I got together with a group of other healthcare policy bright people, and they crossed various groups. Like they were leaders from different grassroots groups. Like I'm a leader within Practicing Physicians of America, what I founded, and so we wrote a paper, and I did engineer the writing of the paper, and I tried to keep to topics that physicians could agree on. Because here's where we go wrong. Those GPOs and those PBMs, they're running to like lawmakers on both sides of the aisle and just stuffing their pockets with money. I don't want to go down and stuff anyone's pockets with money. I want to give ideas into heads. I want this to be about policy and about doing the right thing by patients. So I tried to pick ideas that I thought that physicians would agree on, because we never agree, right? I mean, what's happened in the last 10 years? Everyone on the right stood up and said, repeal Obamacare. And everyone on the left has stood up and said, Medicare for all. And both ideas are really just campaign slogans. They're not real ideas.
Right.
And if you enacted either of those to its full extent, you wouldn't get anything, but the special interests would still run everything, correct?
Right.
So my idea was do things that are actually going to carve out, and I say cut the glut, get the special interests money and control out of the exam room. And so the 5 topics were about drug pricing and drug shortages in the supply chain. That was number 1. Number 2, transparency. Number 3, innovative models like direct primary care. Number 4, innovative models of charity. I mean, like, we let the government do the charity, but like we, the taxpayers, pay them, and that's its own middleman right there. And then the last thing was, how do we ameliorate the physician shortage? So I took 5 arenas in this paper, and then various ones of us wrote about it, and we put it all together. And we came out with something that, like, I have people on both sides of the aisle that are physicians that read it and love it. And the same with patients. And they're like, this is what America needs. And really, truly, if you want to heal a sick healthcare system, stop making it, America now loves its warlords. I love the blue warlord. I love the red warlord. And then we gather behind the warlord's ideas instead of coming forth with ideas of our own. It's supposed to be we the people. So if we recognize healthcare is sick, start with the people that should be leading in healthcare. And we haven't been for a long time. And get people with ideas across the aisle to fix it and to remove the obstruction that prevents us from doing the best job that we can, from treating our patients the way we were trained. And so when that happened, we wrote that paper, and all of these, the coalition almost organically formed. And now we have almost 30 groups representing 8 million citizens, of which over 70,000 are physicians. And I think all of the groups have grown. It might be 80 or 90,000 for all I know right now. We should recount, really. But who has time to count in the middle of all this?
Right. That's fantastic. Did you find that did you find the Trump administration specifically fairly responsive to some of the pushing that you and Rupali have done?
Well, the paper was written in April 2019. By the time we hit July of 2019, there was a transparency order. So someone was paying attention. I mean, I didn't have direct contact with the administration.
Yeah. Who's paying attention? How do you, I mean, I know you're a powerful person, but you can snap your fingers and suddenly, Dr. Chadha is on the White House lawn signing papers. How exactly does it happen?
If you stacked us on top of each other, we would be far below 10 feet. I'm just saying. Powerful person. So cute.
Marion and I are both about 5 foot.
Well, I'm not that much taller.
I think that there were, all of us took the paper, and I think what we did was we sent it out to people, and we told them, talk to your representatives, talk to your senators. I mean, I certainly did it again and again. Maybe eventually all of that word got around. I mean, and then maybe that fact that people were talking about this group that had gathered and that was nonpartisan, I'm guessing it's really just the power of grassroots. I can't say.
I have to agree with that. I mean, we, when I do the town halls, it's not so much that I think the candidate is going to win and is going to go do something. I think the candidate's going to get to DC, and then like the swamp will like envelop them. It's more that I'm talking to individual people, and at the end of the talk, I tell every single person in the room, You have a phone, you have email your congressional representatives, email your senators, and tell them, I want you to repeal safe harbor. In fact, Marion has a little script that you tell people to say. And not just that, I mean, the little, whatever platforms we may have on social media, we scream it from the rooftops. And I think that regular folks, like patients, all of us are patients, are listening, because who likes going to the doctor or going to a hospital and getting, paying your copay, you pay your premium, and then you get like a lovely little envelope with a surprise bill. Nobody likes that. Everyone's pissed off. Everyone's scared. No one wants to be sick. I mean, we have a sick care system that doesn't even work, let alone a healthcare system. So I think the word of mouth, I think it just got around. And elected officials are only going to listen when their constituents say, yo, this sucks, do something. So that's what I think is happening.
No, that's great. That's really great. Well, it's been it's really great. I mean, it's really inspiring, and hopefully we can get more and more physicians involved. And it's daunting, but it's been interesting to see. We've had more and more physicians running for Congress. I know I had Manny Sethi on. I don't know. Do you guys know Manny Sethi? Dr. Sethi from Tennessee. He's a senator. He's running to be the next senator of Tennessee. He's been endorsed by Ted Cruz and whatnot. So we had him on our last podcast. And he again he's a trauma surgeon, and he's obviously comes at it from a very different approach, and is not at all a fan of the establishment in terms of where the establishment has kind of traditionally gone to butter their bread, which is insurance companies, GPOs, PBMs, and he seems to kind of have a good sense and a good head on him. And then of course there's this massive movement that has been helped along by Dr. Fisher, who's been wonderful on so many different fronts. He's who's also a cardiologist, and then of course you, Marion. So it's really great. Marion, I didn't even know you. I mean, you're in Philadelphia. We're local. We probably live within 10 miles of each other. So
I know you have to come for dinner. You can't believe my tomatoes. They're the
really?
best tomatoes in the whole county. It's true.
She has an amazing garden. I'm like, every time she posts, I'm like, I'm hungry now. How do I get there?
Wonderful. Well, hopefully one of these days we'll all have to meet up so it's not just virtual. So, but thanks so much for coming on, giving some of your time. I know it's super, both of you are super busy. It's really, really great. Any comments, any last things that you want, messages or something that you want to get out?
Marion?
Rupali, you go first.
I guess I want your listeners to know that you're not helpless. If you have anything that you feel unhappy about, we can't control other people. We can't control our universe, but we can certainly control ourselves. This is, I guess, my psychiatrist message. And the way you control yourselves is in your reaction to things. So if you are upset about the way healthcare is, then you can do something. And if you're a physician, you can join any one of the grassroots organizations and Free to Care. And if you're a patient, you have a phone. You can call your representatives and do something. So, people forget that our elected officials, they're beholden to us. They're supposed to do what we want. Yeah. And if they're not, not only voting, I mean, voting is an important thing, whether you vote, however you vote for your interests, vote for patients. But in addition to that, once they're elected, they work for you. They have to do what you want. So pick up the phone and go down, make meetings, and make a ruckus. Every American to do that.
So you're telling me that just angrily tweeting doesn't get me anywhere? Is that what you're saying here?
Actually, I'm new to Twitter, but I think that Twitter has a place because it can get people, I mean, it's a bit of an echo chamber sometimes, but it can get people thinking about things. And if you have a platform on Twitter and you are motivating people to be, to use their anger in a useful way and giving them information, you have your one or two witty line tweets, but then you give them something useful to do to follow up on that anger. That's not a bad idea. But yes, get off social media once in a while, get out to the real world, and
actually pick up the phone and call your elected representative to tell them that you're unhappy, as opposed to shouting out into the void and feeling good about that.
Tweet them,
that's a good message.
But then follow up with a phone call.
Right. Eat and chew gum. We can do both things. So a lot of times physicians just like to, I get the sense that we like to complain a lot and we want somebody else to take care of it. So anyways, I'm hoping I can continue angrily tweeting and you and Marion can take care of actually.
I need to see your angry tweets now. I'm going to head over.
Marion, any last comments?
Yeah, I guess I would just say, to physicians, this is your profession. This is your future. You took an oath. I think we have a higher answer than just like taking care of the patients that we see in front of us. We have to do something about the future. We have to take that on our shoulders without laying blame on the past. And if we don't, it's not just going to be us as, the old geezers in the nursing homes of the future that are going to pay. It's going to be our children, our grandchildren, our great grandchildren, et cetera. And for patients, I really want to echo what Rupali said, and all of us are patients, physicians included. Stop complaining, start unwinding, start understanding this system, and hold those people who are making the rules accountable, because they do work for us.
Excellent. So the organization that Marion helped co-found with Wesley Fisher is freetocare.org.
Practicing Physicians of America, and we're part of that Free to Care Coalition.
Oh, sorry. I apologize.
Yes.
Practicing Physicians. Right. No,
okay.
My fault. Practicing Physicians of America. And let's get your Twitter handles. Marion, your Twitter handle is?
Oh gosh, I have to go look it up. Rupali, you say first. Because I got kicked off of Twitter the first time I tweeted about.
Oh my goodness.
True story.
Yeah, there's a lot of Twitter jail. That's another thing. Censorship of doctors, whether you agree or disagree. I mean, come on. So,
really not good.
So my Twitter is just my name. It's Rupali Chadha MD. So it's not an easy name to spell. So RUPALICHADHA MD, and that's my Twitter. And come join the conversation. I actually do my best to read as many follow-up tweets and comments as possible and respond when I can.
Fantastic. And Marion, I looked you up. You're at Mass_Marion. Yep. Is that right? At MASS_MARION. So.
Yep. And that's #patients first, #scrubs not suits.
Love it. Alrighty. Well, thanks so much, folks.
Thank you.
Excellent having you on.
Thank you.